Welcome everyone to Current Thoughts on Angle Closure Glaucoma. We have the privilege tonight to have Dr. Sowka as our presenter. And for those who don't know Dr. Sowka, Joe served as the professor of optometry at Nova Southern University College of Optometry for 28 years. While there, he served as chief of advanced care service, director of the glaucoma service, and chair of the Department of Optometric Sciences. Joe is also a founding member of the Optometric Glaucoma Society and the Optometric Retina Society. He also is the chair of Neuro-Ophthalmic Disorders in Optometry for the American Academy of Optometry. Most of you might know Joe as a gifted writer. He's written hundreds of published articles, and he's also the lead author of the annual handbook of ocular disease management, and that's by Review of Optometry. Joe, thank you for doing that. I know it's well read still to this day. Joe is also a well-known national and international lecturer. Last year in April, Joe moved from Southern Florida up to Sarasota, Florida for Center for Sight. So please give Joe a big virtual welcome for tonight's presentation. Joe, looking forward to it.
Thank you, Greg. Well, our topic tonight is current thoughts on angle closure glaucoma. This is one of those conditions that, a lot of clinicians dread, fear, are apprehensive about because there can be several mechanisms. There's no one standard treatment with this condition. There's high potential for morbidity in this, and a lot of people are very uncomfortable dealing with it. Yes, we all make a few mistakes here and there, but I'm going to try to simplify things, give you a lot of work on the pathophysiology and how we manage it. And it is a pretty interesting and challenging type of condition, and there is a definite potential for morbidity. This afternoon over lunch, I was reading depositions and records from a malpractice case where the doctor allegedly had missed angle closure glaucoma. So this is something we really do need to consider. Now, in my disclosures, I'm a consultant or speaker bureau member, advisory board member for Novartis, Allergan, Glaukos, Zeiss, Aerie, Ocular Therapeutics, and Bausch & Lomb. But I've got no financial interest in a product, disease, or instrumentation that I may actually mention. I prepared this lecture independently, and I am a co-owner of Optometric Education Consultants with Greg. Now, what is angle closure? How can we think about this? Well, technically, and I will be technical about things, it is a severe type of glaucoma caused by the apposition of the iris to the trabecular meshwork, and that obstructs aqueous flow. And this happens due to forces at 4 potential anatomic levels. When I say successive, they don't all happen at once. These are options. It can be at the pupil, which is known as pupil block, the ciliary body, which is a plateau iris syndrome, the lens, phacomorphic, and other vectors posterior to the lens, including malignant glaucoma. So there's about 4 places where this can go wrong: the iris, the ciliary body, the lens, or things behind the lens. So we have to be very, very cognizant of what's happening, because if we sit and think about it, we can come to the right answer. Now here's polling question number 1. Okay, we have anterior trabecular meshwork only for 180 degrees, pigmented trabecular meshwork at under 180 degrees, and pressure 28. What do we say this patient has? So pressure is elevated. You see anterior TM only, barely anything. There's Schwalbe's line for 180 degrees. And the other 180 degrees, you got pigmented TM. What's our diagnosis? Is it open angle glaucoma? Is it closed angle glaucoma? Is it narrow angle glaucoma? Or I'm not really sure. That's why I'm here, which is an acceptable answer. Okay, Greg, we're moving through nicely.
Yes, we are. Give it about another 5 seconds and I'll end the poll.
We got two going neck and neck. All right. Edging out narrow angle glaucoma is open angle glaucoma. Very good. Excellent. Well, here's a common term that we use. I think many optometrists and many ophthalmologists use this term, narrow angle glaucoma. And what I want to do is, through this education tonight, is we need to strike through this. We need to remove this from our vernacular. There really is no, even though there may be a code for it, there really technically isn't narrow angle glaucoma. The angle being narrow doesn't cause the pressure to go up. It doesn't give glaucoma. It's either open or closed. So we have to talk in terms of open angle glaucoma or closed angle glaucoma. There's no intermediate narrow angle glaucoma. It's an old term. It's not a good term. I'd like to see us stop using it as soon as we can. Here is our current terminology. I'm going to go through what each one of these means. We've got primary angle closure suspect, which is actually very common. We've got primary angle closure, which is common. We've got primary angle closure glaucoma, which is the next step up. And of course, what we all know about and tend to dread is the primary angle closure attack. So what do these all mean? What are the current definitions? This is current thoughts. What is the current thinking? What is a primary angle closure suspect? This is a person that we see weekly, if not daily. This is a person who has got usually a moderate amount of hyperopia. And we look gonioscopically, and the pigmented trabecular meshwork is blocked by the iris. Now, nobody really agrees how much has to be there. I always get concerned once we get more than 3 clock hours and 90 degrees, but most people agree 180 degrees of no pigmented trabecular meshwork is going to be a suspect. Now, there's no peripheral anterior synechiae. The disc and the pressure is all normal. And these are the kind of people that we have to probe for symptoms of intermittent angle closure, the retroorbital ache or headache that happens at night, the halos around lights at night. I will tell you, intermittent angle closure is a very difficult disease to actually diagnose. In fact, many times when we make a diagnosis of intermittent closure, it's by supposition. Now, for these patients, we don't know if laser iridotomy or observation is better. These are people who, moderate hyperopia. We don't see pigmented trabecular meshwork for about 180 degrees, and we don't really know what to do in these patients. Well, a few years ago, out came the ZAP study, where they actually tried to identify this. Now, this was done in China. The reason it was done in China is the high prevalence of angle closure glaucoma they have over there. And essentially what they did was randomize these patients where one eye was treated with laser iridotomy, the other was not. And the goal was to, kind of see what happens. Would they develop elevated intraocular pressure? Would they develop peripheral anterior synechiae? Will they develop disc damage? Will they go into an actual acute angle closure attack? And they had a pretty good number, almost 900 suspects that I just described. One person got a laser iridotomy, the other was observed. And at 24 months, 72 months, what they're looking for is elevated pressure, some synechiae, or the acute attack. And what they found was, laser iridotomy was actually beneficial. The outcome was a little over 4 per 1,000 eyes per year if they got laser, and about 8 per 1,000 eyes per year. And we look at it, ultimately, an endpoint of a pressure elevation, peripheral synechiae, or actual acute attack happened in 19 eyes that got laser and 36 eyes that didn't get laser. So it did reduce the risk of going on to true disease from suspect. But what was really important to take home is there's a really low rate of angle closure. When we look at almost 900 closure suspects, and when we look at it, 19 and 36. Those were low numbers who actually got into trouble. So yes, it really did reduce the risk of getting into true glaucoma or other disease progression by about 47%, but the rate was very low. It's less than 1% per year. And this is not the whole population. These are people of closure suspects. So what does that tell us? Well, we have to consider that these are all a unique, subset of patients. These are all Chinese patients. Can I apply that to a Caribbean Black population or a Midwest Caucasian? Not necessarily, but what this tells me is there's not a huge rush to get the LPI done in a situation like that. You've got time to think about it. And the likelihood that they're going to close is actually relatively small. Now, I don't know if Greg was at that Glaucoma Society meeting the year we had a fellow named Harry Quigley. And Harry Quigley is an internationally renowned glaucoma specialist out of Wilmer, Johns Hopkins. And he said, even he doesn't know who's going to close in the situation. He said, sometimes you just got to bite the bullet and dilate and see what happens. But he said, you don't do it 4 o'clock, 4 o'clock on a Friday. You do it 9 o'clock on a Friday, and you tell them you're going to be here until after lunch when the dilation wears off, and see if they actually go into an attack. Now, it brings me to primary angle closure. Now we're getting pathologic. The pigmented trabecular meshwork is blocked for at least 180 degrees. You really don't see the structure. And they either have synechia or elevated pressure or both. But there's no disc, nerve fiber layer, or field loss yet. No damage to anything there, but this is considered pathologic. This is the next step up. And for these patients, laser is indeed recommended at this time. I'll take the next step up. We still have that blockage for 180 degrees or more. And they have either synechia or elevated pressure or both. And they actually have glaucomatous disc and there's field loss and nerve fiber layer damage. And again, this is recommended to undergo laser iridotomy. And finally, what we all know about and probably saw in optometry school or a residency is the acute primary angle closure attack, where there's a near complete apposition of the iris to the meshwork. You really see no structures. There are a lot of classic signs and symptoms that are not omnipresent, and they don't all need to be there. The eye tends to be red. It's inflamed. They will often have vision loss from corneal edema. They're often nauseous, halos around lights because of corneal edema. Pressure can be markedly elevated, in the 40s or higher. Of course, there's inflammation. And the pupil tends not to be reactive. It's that fixed mid-dilated pupil. That's actually a very important finding. Now, one may wonder why are these people so symptomatic, and why are they nauseous? Well, why are they vomiting? Well, that's a good question. It is really an evolutionary response. When the cornea becomes acutely edematous, it does disrupt the vagus nerve. Vasovagal syncope, that will actually induce nausea and vomiting. What happens to somebody who vomits? Why are they vomiting? Well, they're vomiting because the eye is trying to dehydrate itself, or the body's trying to dehydrate itself. Because people who are vomiting a lot become dehydrated. It's the body's attempt to lower fluid pressure. Now, these are people who are probably going to undergo medical therapy, iridotomies, maybe an iridoplasty, which I'll discuss later, possibly trabeculectomy, but trabeculectomy puts at now the risk for another type of angle closure glaucoma called malignant glaucoma. And one may argue lens removal might actually be the best thing to do if you can get it out safely and quickly. So here is just a table that really kind of lists everything: primary angle closure suspect, primary angle closure glaucoma, acute angle closure, and it kind of summarizes everything we just talked about. So This will be in your notes, and please enjoy. Now, angle closure glaucoma is a particularly malignant type of condition. It's the second leading cause of blindness worldwide, and vision loss is more common in angle closure than glaucoma than primary open-angle glaucoma. Now, out of the 7 million people who are blind worldwide from glaucoma, 4 million are blind from angle closure, and it is not a particularly prevalent form of the disease, of glaucoma, so it's obviously more malignant. It was predicted by 2020, primary angle closure would be affecting about 20 million people, and about 5.3 million people would be blind. I'm not sure exactly how we met that expectation or that prediction. Now, it helps to know what is the patient profile, what to look for, who to look for. And I think in my practice, in my glaucoma service when I was at the university, it was fairly predictable. Now, it's more common in Caucasians and patients of African descent. It has been said that it's uncommon in patients of African descent. I disagree with that. I've seen a number of angle closure cases in patients of African descent. In Asian population, angle closure is probably more prevalent than primary open angle glaucoma. It is more common in females than males. It is more common in older than younger people. And obviously much more common in hyperopes than myopes, because hyperopes have a smaller eye and there's less volume there. Now, the native Inuit population actually has the highest incidence of angle closure for those. So those of you who are in that endemic region, you're going to see that probably more commonly. So right there is your classic picture. A Caucasian older woman with a small round eye, small round face, small round body, small round glasses. And typically her feet dangle from the chair because she can't reach the footrest. That is your typical angle closure glaucoma. Now, one thing I would strongly recommend, I'm going to say it now, I'll probably come across it again later. I think the best way to reduce vision loss from angle closure glaucoma, we can all do this, is to do gonioscopy on every phakic hyperope over +2 to 250. If you want to push it, say 250. Every phakic hyperope over 250 to me can be listed as a glaucoma suspect. They're going to have it somewhat narrow angle, put a gonioscopy lens on, and yes, this is a legitimately billable procedure, and look and see if they fall in those categories of what we just discussed. So there are classes of angle closure. There's primary angle closure with pupil block, which can be acute, subacute, or chronic. There's primary angle closure without pupil block, which is plateau iris syndrome. And there's secondary angle closure with pupil block and without pupil block. I'm going to go through each one of these in detail. I'm going to start off with primary angle closure with pupil block. That is an important concept to understand, pupil block. Pupil block is a physiologic process. It's normal physiology. Everybody who is phakic, who has their crystal lens, has some degree of relative pupil block. That is just the apposition of posterior iris to the anterior lens. Now, when a patient iris is and pupil is in mid-dilated state, that apposition is the tightest. That's where most of the problems occur and where they get stuck. That's why it's the fixed mid-dilated dilated pupil. So pupil block is normal physiology if you're phakic, but some patients will develop a pathological problem for this. When this blockage is so tight, there is no egress from the aqueous to get to the anterior chamber. So we get a pressure buildup in the posterior chamber that allows for iris bombé of bowing forward the iris due to this pressure buildup. That's what forces the iridocorneal apposition or the iridotrabecular apposition. And bada bing, bada boom, you have closure of the angle. And this is what I'm describing here. This is pupil block. This is what we all have if you're phakic. And there's just a fairly snug apposition here. This is physiology. but aqueous can still get diffused anteriorly through there. In a rare few, physiology becomes pathology, and this apposition is abnormally tight. There's more production than there is diffusion forward, so pressure builds up. We have iris bombé closure with apposition to the cornea and or the trabecular meshwork, and subsequent angle closure, that bulging forward or bombéed iris. So aqueous is not getting out. Aqueous is not getting through here. It's not getting out. Pressure elevates. It does so sometimes acutely. We have a bit of a problem. Now, what we have all learned to do is screen patients with, von Herrick. We go to the edge. I will tell you, I think it's a very weak screening tool. There are a number of patients where I've actually seen a relatively open von Herrick angle. I mean, nothing that was especially troublesome, yet they had angle closure. And I've actually seen very narrow angles where I put a gonial lens on and I see, at least pigmented trabecular meshwork all the way through. So looking here is what we've all trained to do. We still do it. We should still do it. And if we're worried, we put a gonial lens on. But it's more important to look at what happens further out. Look at the mid and the central chamber. We can certainly see in this eye here, there's a huge depth. There's plenty of room there. Here, not the von Herrick at the limbus, but halfway through, you can see how narrow that is. This is the person who's going to be in trouble. This is the one that I'm actually more worried about rather than this one, is when we start to go over here a little bit and it's centrally shallow. And right here, we can certainly see there's virtually no chamber because this is the person who's got posterior synechia and the secluded pupil. So don't so much worry about over here, but don't be afraid to come over here to check the depth and see, we're all experienced practitioners. We can look and determine, is that truly deep or is that actually worrisome shallow?
Hey, Joe, go back on that one picture if you would.
Surely.
And, my comment would be, we can probably learn from a pseudo-exfoliation patient that's dilated, because you see, when they're at center of that part of that lens, when they're dilated, where that pseudo-exfoliative material is, and then they get that donut ring right about where those optic sections that you have going through that cornea, where that iris on that back surface has rubbed that anterior surface. You can show how tight it is, or the touch is, because it rubs off that pseudo-exfoliative material. So we can learn from the pseudo-exfoliation patients and to kind of, show how tight that really is. And then my other comment would be, we talk about a lot of gonioscopy, and I truly agree. Gonioscopy definitely needs to be done. And it was about 18 years ago, 20 years ago, when I wanted to get good at it. And I decided, you know what? I'm going to make it a part of my routine daily care for 2 weeks, because you don't know what's abnormal until you kind of know what's normal, and you have to go through a lot of ends to get that normal in a sense. So I did gonioscopy on every patient for about 2 weeks. So that'd be a little pearl for you guys out there, if you want to get good at gonioscopy. So those are my 2 comments. I'll let you take it over from there.
Those are excellent comments, Greg. When you put a gonial lens on, you may be looking at over a crater. You can't even peek over the edge of the iris to see if there are any structures there. Now, indentation gonioscopy, and Greg, you can weigh in on this. Indentation or dynamic gonioscopy, where you start to press on the eye to see, can you open it, is, in my opinion, kind of a bit overrated. And I'll explain to you what I mean is, in a person who's got what seems to be a shallow chamber, you put a 4-mirror lens on around a flange, and you start to press on it. If the patient has a pressure in the 16-15 range or lower, you're going to indent and warp the cornea and not be able to see well. Indentation gonioscopy tends to work best when you're 20 or above. And you start to indent and the cornea doesn't work. And you can actually see the structures then. But this is just a nice, depiction we have right here of that classic iris Bombay where there's apposition. There's probably some areas of where it's still open. Aqueous may be draining, but may be draining insufficiently. And here are a number of things we have to really kind of take a look at and understand the dynamics. This is really a classic iris Bombay here. You can see the iris bulging forward. Here, it's not really quite as much a Bombay as maybe it's plateaued. And this is certainly one that is plateaued where it seems relatively deep here, but it's very shallow. This is a very unique situation. This is not iris Bombay. This is a flattened chamber. And that usually occurs due to choroidal issues, which we'll talk about toward the end of the lecture tonight. Now, primary angle closure pupil block, that iris is in apposition to the meshwork for too long, it's going to get stuck there. Sinical closure will occur. It happens usually pretty quickly. Now, historically, we've always myosed these patients. We put them on a pilocarpine because that one helps break the pupil block. It helps drag the iris out of the angle, but really anything that alleviates that iridolenticular mid-dilated state should work. And that includes cycloplegia or mydriatic agents. But, honestly, very few doctors feel comfortable dilating a patient in angle closure, though that may actually be the right approach for a given patient. It's just that meiosis has long been our standard, and people still do that. Of course, in the acute situation, pressure can rise very high, 40s to 70s or even higher. I've heard possible vascular occlusions develop due to the elevated intraocular pressure. I have never actually clinically seen that occur in any sort of a acute situation. But of course, synechia will form relatively quickly, and that tends to be permanent unless it is surgically rectified. Now, what are the anatomic features of these patients? They have small corneas. They've got a smaller axial length. The axial length is 5% shorter in patients with angle closure than age-matched controls. A moderate degree of hyperopia, and I usually start to see this, 1.25 and higher. Certainly when you get into the 2.5 and 3s, it's more of a risk. The lens tends to be a bit thicker, and there's a greater propensity for the lens to move forward, leading to pupillary block. Now, here's something that we can always use the OCT. If we can measure the depth of the anterior chamber, not only are we looking at the profile and the iridotrabecular relationships, we can actually measure the anterior chamber depth. And that is near central, close to the pupil. And the anterior chamber depth is more than 2.5 millimeters. You almost never see angle closure glaucoma. If it's 2 to 2.5, sometimes you see it. If it's less than 2, you can often see angle closure. And about 3/4 of the angle closure patients have anterior chamber depth less than 1.5 millimeters. That's why I suggest looking biomicroscopically, at the mid-peripheral area. Is it shallow, not just at the limbus, but is it shallow further in? And the anterior chamber is about 1/4 shallower than age-matched control. The volume is about 1/3 less. Now we got acute, we got subacute or intermittent, and we have chronic angle closure. And I think we all know acute primary angle closure, pupil block patients, they have the red eye, they're photophobic, their vision is reduced from the corneal edema, they may have halos, they have very blurred vision. They can have nausea with vomiting because of the vagus nerve being stimulated, trying to dehydrate the patient. And there's usually that mid-dilated state. That's where they get into trouble, and the pressure elevates and it kind of gets fixed in there. The iris becomes ischemic. It doesn't really move, and it's kind of hard to get it off of there. you're going to have that cloudy corneal edema. Here's a term. I didn't teach it for many years until it showed up on national boards, and I get chastised by the students for not mentioning this historical factoid called glaucoma. Greg, do you remember glaucoma? You remember what that is?
Yeah, I mean, we had to learn it for boards, right? I believe that's when the pressure goes high and it kills, the anterior epithelial cells of the lens. If that's what I remember, but that's about all I remember.
Yeah, that's it. It's a historical factoid, and that usually is supposed to be indicative of acute pressure rises. We had this necrotic lens capsule. This is a patient I had. But this was not angle closure. This was a patient with old uveitic glaucoma that had glaucoma. So it's an old term that I don't really care to actually use. But this is your classic patient, the red painful eye, the very edematous cornea, and you really can't get much in terms of gonioscopy. Now, here would be a brain teaser. I don't think this is a polling question, but this would be a brain teaser. I can tell you right now, a person like this, if you were to put the gonial lens on, you're not really going to see a heck of a lot in there. It's going to be cloudy. It's going to be hazy. Is anything else going to look like this? Sure, uveitic glaucoma can look like this. Now, is it important to differentiate? Well, sure, because historically, one of the medicines we use are the miotics for angle closure. And miotics are not anything that you want to use with uveitis. So the question becomes, if you can't see the angle, how do you differentiate? The answer is put a gonial lens on the other eye. Primary angle closure rarely comes bilaterally simultaneously. If it comes bilaterally simultaneously, there's other mechanisms, which we'll cover a little bit later, such as choroidal expansion. But if it's primary angle closure, the other eye should be at risk. If you put a gonial lens on the other eye and you have a wide open angle, you're probably not dealing with primary angle closure. It might be a secondary angle closure and uveitis. But if the other eye is narrow, that narrows down your diagnosis to angle closure glaucoma. So that entire angles typically involve vision loss, nerve fiber layer loss, nerve damage, field loss can actually happen within about 48 hours if the pressure spikes up and the patient can't really compensate. Of course, they've got profound signs and symptoms. Pressures in the 40s or more will be very common. When a person comes in with chronic open angle glaucoma, primary open angle glaucoma, pressure 40 to 50, that pressure has been going up very slowly for a significant period of time. The eye is compensating. But when the pressure goes from a 15 to a 45, the eye doesn't have time to compensate. The sodium potassium pump on the endothelium shuts down, the cornea becomes turgid and edematous, and we start to have these issues. And again, Sinical will form quickly, and will often persist even after breaking the attack, and it will probably cause irreversible trabecular meshwork damage. Now, how do we deal with this? Well, first and foremost, we need to reestablish communication from the posterior chamber to the anterior chamber, from the anterior chamber to Schlemm's canal. And we do that by trying to reduce the pressure. Why are we reducing the pressure? We're trying to get that ischemic iris to move again. And if we get it to move again, either midriatically or myotically, we can help break the pupil block. This is the acute management that we have to deal with. Now, beta blocker, a drop once, twice. We don't want to be overdosing patients, starting pouring this in liberally, because next thing you know, grandma don't breathe so well. Now, pilocarpine 1% or 2%, we should always have some in the office. That usually works if the pressure is less than 40. Now, if it's above 40, the iris tends to be ischemic, doesn't really move. But make sure you know what the diagnosis is before you start pouring pilocarpine into the eye, because if it's primary inflammation causing the pressure to elevate, we can be making it worse. And we don't want to go anything higher than 2% because it can actually congest the ciliary body and lead to a greater pupil block. But 1%, 2%, couple drops, If the pressure is under 40, we can start opening things up. Iopidine versus Alphagan, I don't think that there's any significant difference, to be honest with you. Iopidine has been used post-surgically laser procedures to blunt the IOP spike. We often don't have Iopidine available. Alphagan tends to be a little bit more readily available, and that's a good, it can be equally good, or Combigan is a very good medicine to use. Steroid, not a bad idea. You don't worry about pressure rise. You're gonna quiet the eye down, start working on the inflammation. Now, prostaglandins tend to work a little too slow. You're not hurting the patient, but they don't usually work fast enough to address an acute situation. Carbonic anhydrase inhibitors are usually what's used. Patients can usually safely swallow one-time dosage of 500 milligrams of Diamox, probably 250 tablets and not a 500 milligram sustained release. We don't want slow. Now, if you can't use orals where you are, or they're not available, topicals can be used, if it's not contraindicated, but won't work quite as well. Osmotics, they're just generally not available. I think the last time I went to reach for an oral osmotic, I pulled it off the shelf and I shook it up and it rattled like a maraca. So it was just totally worthless. We generally don't have that. Ultimately, I think most people are gonna recommend a laser iridotomy. It is tried and it is true. Now, I've always thought that putting a hole in the iris was somewhat barbaric, not the best way to do it. It probably isn't, but it is darn easy to do. So that is something that should be arranged as soon as possible. One might say one should never let the sun go down on an angle closure before doing an LPI. Iridoplasty has been shown, but so few people do iridoplasty. I'll talk about that in just a bit. It has been shown to be effective. I don't think that people will readily use it. Some of these patients may need trabeculectomy and tube shunts, but there is a high risk of a patient developing malignant glaucoma from this. Probably the best thing to do is to remove the lens. It's probably best done after the attack has been broken out. If for some reason a patient has a particularly malignant form, lens removal can be done. But of course, anybody who's taking a lens out, wants to have the best surgical outcome, and biometry and everything, so, in terms of choosing the right IOLs can be very challenging. So usually after the attack has been broken, the lens can be removed and that will pretty much solve the problem. So by forming this communication from the posterior chamber to the anterior chamber through a small opening, that will allow the aqueous to diffuse forward, the iris to relax back. If there's not too much synechia, open up the angle again. Now, they typically have been done in the superior area, so it would be covered by the iris. Usually between the 10 and 1 o'clock is where they put it. Now they are putting it more at 3 o'clock and 9 o'clock due to prismatic effects, which I really can't well describe to you or explain to you here. There seems to be less visual aberrations putting the iridotomies out here at 3 o'clock or 9 o'clock rather than 10 o'clock or 1 o'clock. And of course, iridotomy is going to be very relieving. It can open up, it can deepen the chamber, it can relax the iris back, and it's actually very effective and is pretty successful. It is tried and true, and it is relatively easy to accomplish. Greg, before I go on, are there any questions or comments in the chat box I should be aware of?
No, everything's quiet, and that's a good reminder that if you do have questions, please put them in the chat box. I'll monitor them. I did put the handouts in there about 7:08, 7:09. There's the full slides and the 6 slides per page that are out there.
Well, here's one that is hard to make a conclusive diagnosis. It's subacute or intermittent angle closure. This is the patient who goes into short non-permanent recurrent attacks. The pressure will elevate, then it comes back down. And it usually subsides spontaneously because when people go to sleep, their pupils will myose, and it tends to break the attack. There are lesser symptoms. They can have episodic blurred vision and halos, meaning the pressure goes up, shuts down sodium and potassium pump, the vision blurs. There will usually be a partial angle closure when you see these patients. And you should be looking superiorly, especially for peripheral anterior synechial. Cataract can be present. This is what is incorrectly called narrow angle glaucoma. The fact the angle is narrow is not causing the glaucoma. It's the fact that it's intermittently closing. I can think of one case saw at the university where a patient had been seen for about two years for a routine examination. They complained of a periodic retroorbital pain. Now, the student had noted they had actually narrow angles von Heracli, but this was all ascribed to sinus disease until the third primary care visit, and the patient was dilated. And about 6 o'clock at night, the pressure was 60 because it actually had been experiencing intermittent angle closure. Now, this can be incorrectly diagnosed as or confused with normal tension glaucoma because in the office they may be normal, or primary open angle glaucoma. That's why gonioscopy is so important, and very important to look for synechial superiorly. And then we start to probe for the symptoms. And they've got an anatomically narrow angle. They're synechial somewhat superiorly. They don't open up with indentation gonioscopy, and we're probably looking at a case of subacute or intermittent angle closure. These are going to be treated much the same way. Laser iridotomy is very beneficial. Lens removal is probably the best thing, and these are patients we might have some time after it's not such an acute situation. But we don't want to be long-term managing these patients medically alone unless there's no visual potential, because it's a false sense of security. It allows synechial to form and zipper shut. Now, tube or trab surgery can be, obviously the MIGS procedures are not ideal here, but there's a risk of malignant glaucoma with glaucoma surgery for angle closure. So we're going from one situation to what may actually be a worse situation. Now here's a 59-year-old asymptomatic female, complains of mildly blurred vision, mild discomfort in both eyes, but actually had ocular surface disease, which readily explained those symptoms. She's 20/20 in each eye, pressures 38 and 42 right and left eye respectively. Biomicroscopically, she has very narrow angles, and gonioscopically, there's a little bit of anterior TM inferior in each eye in both eyes. And we can see what her fields look like there. So, Greg, that brings me to polling question number 2. What is this patient's diagnosis? Is it open angle glaucoma? Is it acute closed angle glaucoma? Is it chronic angle closure? Is it narrow angle glaucoma? Or I'm not sure. That's why I'm here. Now I'll step back so people can see it. Okay, people are working through this. I think they're doing very well. Is it open angle glaucoma, acute closed, chronic closed, narrow, or I'm not sure. And it looks like somebody found their way into the drawing, so if you can stop drawing, I'm going to have to, once we end this polling, I'm gonna have to stop sharing the screen for a moment. All right, Greg, why don't we just call it here? So the vast majority, or the majority have said chronic angle closure, and I think I'm gonna have to agree with everybody there. Okay, so let me stop sharing for just a second. Now I'm going to share my screen again. We don't want that to happen, did we? Yep, there we are. So please stay away from the drawing and the erasing, the drawing on the Zoom, because it shows up here for everybody. Okay, so this is a person who has primary chronic angle closure glaucoma. This is actually the most common form. It's about 80% of primary angle closure glaucoma. Acute is only about 20%. This is asymptomatic, and this is a combined mechanism type of glaucoma. It's not all pupil block. In fact, iris Bombay is not a huge component here. There is a Sinical Zippering shut of the angle. It usually begins superiorly and moves outwards, starting to zipper up all the angles. This is often discovered on routine examination. And if you don't do gonioscopy, you can easily mistake it for primary open angle glaucoma. These are patients with chronically elevated pressures. They don't have symptoms, but it is a chronic angle closure disease. And so this is a multi-mechanism. It's a creeping closure. Pupil block is in there, but pupil block is more acute or subacute. There are some non-pupil blocking mechanisms. These patients usually have a deeper anterior chamber, and they actually tend to be younger. They can be under the age of 40. And this is an iris crowding mechanism and an anteriorly positioned ciliary body against the root of the angle. So not so much pupil block. There is pupil block involved, but it's not the main mechanism. It's more an iris crowding because of the position of the ciliary body. Now, these are patients who will, any angle closure that seems primary will undergo iridotomy, and then maybe filtering surgery if necessary, if pressure can't be controlled. These patients will typically require medicines after iridotomy to control the disease, even if the angle does open up. Now, you can get good results in most of the patients on medical and laser surgery. Now, there is something called the EAGLE study where they investigated lens removal as a primary treatment for chronic angle closure. It is currently a very viable option. What they actually did to explain this. Patients with chronic angle closure were randomized to two groups. One was a lens extraction, and that was a clear lens extraction. And the other group underwent laser iridotomy and stepped up medical therapy. And what they found was removing the clear lens in patients with primary angle closure with elevated pressures. What they found was these patients had far fewer IOP controlling meds necessary. Only one person who had lensectomy needed trabeculectomy, whereas 24 patients who had been lasered needed trabeculectomy. And there are a lot fewer medicines after FAAO than after LPI. So what the EAGLE study told us was the best way to address primary chronic angle closure is take out the bloody lens. People who underwent iridotomy, they tend to have more complications, need more medicine. Patients who had the lens taken out actually did a lot better. Now, what do we do with clear lenses? Well, that's a bit of a hard press, to get covered for surgery. I'm not sure that this is universally accepted surgery for angle closure in terms of insurance. If there's a cataract there, it's a very simple decision. Take out the lens, take out the cataract, take out the glaucoma. You're really going to be doing pretty well there. Greg, any questions coming yet?
No questions coming in. I do want to make it clear that when you're saying clear lensectomy, that they are putting an IOL back in there.
Yes. Mm-hmm.
They're not leaving the patient aphakic. They're making the patient pseudophakic. They're just taking out a clear lens, as Joe is saying.
And there's some other things. There are other procedures that can also be done, like a FAAO gynecosynostomy. They actually will take the lens out to either cataract or clear lens, put an IOL in, and actually try to cut open the synic areas. It's trying to restore function to a previously closed angle, but there are a lot of issues where even after that's done, the pressure may still not reduce. Theoretically it makes sense, but few surgeons actually perform the procedure, to be honest with you. Okay, polling question. Can you dilate a patient with chronic angle closure? Simple one. Yes, no, or I'm not sure. So a patient has chronic angle closure. No LPI yet. Can you dilate the patient? Yes, no, or I'm not sure.
And Joe, I've measured crystalline lenses with my OCT just because I like measuring things with my OCT, and find that the crystalline lens, in someone say 50 years old, is about 4.5, 5 millimeters. It's usually a little bit less than 5 millimeters. So that probably makes sense of, when you're taking out a 5 millimeter lens out of that eye, that's going to free up a lot of space for things to kind of free up in the eye. So, and I'm not sure how thick an IOL is. Maybe I'll Google that while I'm on here, but I know the IOLs are not 5.5 millimeters thick. So,
All right, so we're going to end the
or
polling
4.5
here.
millimeters.
Going to share the results. Can you dilate a patient with chronic angle closure? Most people say yes. Some people say no. Some people say I'm not sure. That's why I'm here. And the answer is probably. I'm gonna give that one a solid probably. No. If you know a patient has chronic angle closure, you can defer, dilation. But what happens if you do an oopsie? Like you don't know, you didn't do the gonioscopy, you didn't realize it was a chronically closed angle, and you dilate the patient. Have you done damage? The answer is generally no. And why is that? Well, it's not all pupil block. It's sort of like a sinical creeping angle closure. It is more insidious. But I can tell you, when I at the university, I would have a number of patients referred to me for glaucoma consult or glaucoma management, and they had been seen in our primary care clinic, or they had been seen on the outside. They're coming in after a comprehensive examination with elevated intraocular pressure, and they had been dilated. I can see in the record. Was there any ill effect? The answer is, well, no, generally no. So you're not going to make it worse. Would I recommend that you do it? No. You know what the diagnosis is. You can work on getting the iridotomy or lensectomy done first, and then they can be dilated. But if you do an oopsie, you weren't aware, you think you made a mistake, you really haven't harmed the patient. Now, patient with chronic angle closure undergoes laser iridotomy successfully. The angle opens the scleral spur in both eyes. Pressure drops to 19 without meds from, 45. At 3-month follow-up, pressure is now 27. At 6-month follow-up, pressure is now 35. What's going on? That brings me to the next polling question. What's happening with this patient? The LPI is not patent. The angle closed again. The patient has mixed mechanism glaucoma, or I'm not sure. That's why I'm here. So going back, diagnosed chronic angle closure glaucoma, undergoes LPI, angles open up, pressure drops down, then it goes up, then it goes up again. What's going on here? LPI is not patent, the angle is closed again, patient mixed mechanism glaucoma, or I'm not sure, that's what I'm here. Think we'll let this go for a full minute, Greg, then we'll end it.
Okay. Looks like people have slowed down on this one.
Or maybe I didn't give them a good option. The patient has mixed mechanism glaucoma, is what most people have said, and that is probably what most people would think is as the most common answer there. I'm going to stop sharing the results. Well, Mixed mechanism glaucoma is another term we need to strike from our vernacular. We don't want to use that term. Now, I use the term combined mechanism for chronic angle closure, but mixed mechanism. What is mixed mechanism? I've talked to a number of people, I've heard this said many a time, and said, well, the patient had angle closure glaucoma, they were treated successfully, and now they have developed primary open angle glaucoma. Greg, does that seem reasonable to you? That seems a bit far-fetched to me. That's like, to me, you have one type of glaucoma, you're treated, now you develop a second type of glaucoma. That's like being struck by lightning while being eaten by a shark. Okay, that's unusual. Or if you saw the movie The Revenant, where Leo DiCaprio's character gets mauled by a grizzly bear, imagine he gets mauled by a grizzly bear, and as he's lying there, now along comes a polar bear and mauls him again. That's how rare that is. What really is happening is the trabecular meshwork is a very delicate structure. It's right term, it is a hothouse orchid. If it doesn't have the right temperature, sunlight, humidity, it will wilt. Having the iris rubbing against that trabecular meshwork, even if you don't have synechia, it's going to lead to a scarring and sclerosis of that meshwork. When it opens up, yeah, there's a big outflow of aqueous that gets through, but it just doesn't work. You know, the meshwork is now, permanently ineffective, and that's why the pressure goes up. So after angle closure, don't be surprised if they have to have further therapy. Even though the angle opens up, that meshwork has been permanently damaged by that firm apposition. And that's what happens. So we don't want to use the term mixed mechanism. Anybody use the term mixed mechanism is saying to you, the pressure is high, but I don't really know why. That's why.
Joe, a question came in and it says, how quickly can an LPI become non-patent or patent, however you want to say it? Tomato, tomato. How quickly can an LPI become non-patent?
The answer is, if that's gonna happen, it's gonna happen relatively quickly. Probably within, I'm gonna say the first week or so, because inflammation was induced. It was a difficult procedure in this situation. There's a lot of corneal edema. The iris was congested. The person who was doing it had trouble getting through, and they gave up, and they probably gave up too soon. And it was a very small one with a lot of inflammation, and it just closes. So that's just going to happen within the first week or two. Now, if you have a patient who's 6 months out, a year out, there's really no physiological reason for that to scar over. That's, if the opening is big enough and it was patent, that should be sufficient. There's no inflammation. Now, I guess granted, if a person developed years later a bad uveitis, potentially you can have some fill in there, but for the most part, it's going to happen quickly or it's not going to happen at all. Now, prophylaxis, we talked about that. There's some reasons to do an iridotomy in these patients. We went gonio to look for areas of reversible closure, but gonio is not a great predictor. It's a static view of what's a dynamic phenomenon. About 10 people have, out of 10 people with small eyes, one person is going to develop angle closure. So there probably has to be something else involved. And part of that could probably be something like the choroid. Choroid can be involved as well. And remember,
Joe, you'll be excited. I figured out how to erase those marks on the screen so you don't have to unshare anymore. I just Googled it. So.
Excellent. Well, you can Google everything, I guess. Google that stuff. Well, let's talk about the next. That's primary angle closure with pupil block. What about primary angle closure without pupil block? That is the plateau iris syndrome. A chronically underdiagnosed and underrecognized form of angle closure. This is an anatomic variant of the patient, but there is no pupil block. This is this description of an eye with a deep chamber and a narrow angle because they've got a very big last roll of the iris. Now, laser iridotomy occasionally helps. We don't really know why. Iridoplasty has been seen as one of the most common procedures to do, but not many people are familiar with it. And I guess you can say it's questionable as if this is something that should be done. But this is clearly a situation where the dilation will crowd the angle and permanent Sinical can easily form here. And this is what, a depiction. You've got that large glass roll of the iris. It's plateaued. So when they dilate, they actually will block the trabecular meshwork. While the chamber may be deep, there's no iris bombay because there's no pupil block. Aqueous can get out through here, but it can't get out through here because there's an anatomic variant, that glass roll of the iris. And this is a great example, I think, right here of plateau iris. This is a fairly good example right here. You can see how it is all bunched up, and the trabecular meshwork is way back down. Now, gonioscopically, when you do an indent, this is hard to appreciate, but you can have a double hump. You go up here, it bows backward here, and then humps up here when you're pushing on with your gonioscope. Or another example, if you go over, it dips down, then it dips back up again with indentation. This large roll right here is pretty diagnostic of plateau iris syndrome. Or just simply you put a gonial lens on, you can't really see over into the angle.
So just let me give a little pearl. I know we
Yes.
used to teach it whenever we did the therapeutics courses, and just want to do a quick reminder that if you're going to do indentation, most optometry offices were at one point, told to get like the Goldman 3-mirror lens, and it has the 3 mirrors, the one for the angle, and then obviously the other 2 for the retina. I guess the third, the thumbnail mirror, could be used for the far periphery, but you can't really indent if the force is on the limbus. That's when you start getting into the that Volk, the 4-mirror lens without the flange. That doesn't have to be Volk, but that just whoever makes the company, it has to be held. Kind of, it's the size of the RGP lens. It's probably about 4 or 5 millimeters in size, and then you can indent. So you're not going to be able to indent with a 3-mirror, is my point, or one with a flange that we're talking about.
I guess it would be an appropriate place to, to discuss what lenses we like to use. And I personally, Greg, I like to use a G4 gonio laser lens with a flange. I use a viscous artificial tear as my contact solution. You're right, you cannot indent with that type of lens, but the optics are the best. So I will do that. If the angle is open, I'm done. But if the angle is not open, I also have a G4 gonio laser lens without a flange, which I can now do indentation gonioscopy. Now, people don't like to, some people don't like doing gonioscopy. Sometimes you may need to do it twice, do it with different lenses. What are your favorite lenses, Greg?
Yeah, I do have a laser lens in my office. Like you said, it does create the best optics if you're starting to get where you need to really see what's going on in the angle. I do like the 4-mirror lens without the flange. It's quick, it's easy, numb the eye, and then you can see all the different areas of the angle pretty easily. So I like my 4-mirror, and it does. Like I was talking about, whenever you do your first 2 weeks, you're going to indent most everyone, because most people are going to have low pressures. Like Joe mentioned, you're going to have maybe a 16. Everyone's going to have that heavy hand. You start to get that nice feel where you can just set it on the eye and kind of spin to get the different angles. So you will know when you're pushing too hard, because it will become a cloudy view from all the folds. But I do like the 4-mirror lens, Joe.
This is just a depiction of iridoplasty, where an argon laser will actually deliver low power, low energy, long duration burns all the way around the iris. These are not holes. These are not iridotomies. These are just laser scars. And the whole reason behind it is it causes the collagen to contract, and as it contracts, you know how you touch an earthworm and it like wiggles away? Well, that's what the iris does. It kind of wiggles away and it kind of pulls it out. And this has been reported to be the procedure of choice for plateau iris syndrome. The reality is it's not commonly done. Even though it is not pupil block, removing the lens is probably the most efficacious, though it is not as effective as primary pupil block. But taking the lens out, you still do get a little more room there. The issue is that large last rolled iris. It may still, even with an IOL, may still cause blockage. And these are people who end up may actually needing a tube implant. So those are the primary angle closures, primary and secondary with and without pupil block, both of them. Now, we can have secondary angle closure with pupil block. Let's talk about that one. There are many causes, but there's something else that blocks that pupil. It can be uveitis with posterior synechia, phacomorphism with a thick lens, aphakia with a vitreous protruding through, vitreous prolapse, pseudophakia with the IOL dislocates or is put in a bad position, reverse pupil block from anterior chamber lens if there's no iridotomy or iridectomy put in, or if the lens subluxates or dislocates forward. These are all things. So there are numerous causes here. And this is just an example. We have tumescent lens causing pupil block. Here's an anterior chamber lens blocking the pupil. We can see the iris bombay. These are all potential things that can do it. Now, here's a case, what I call a case of a non-routine eye exam. This is a person I got called into one early evening at our clinic. 50-year-old male coming in for a complete eye exam. He's 20/40 in the right eye, 20/40 in the right and left eye. Very high myop. He's an 18 diopter with 250 sil, give or take, in both eyes. His pressure is asymptomatic. His pressure is 42 in each eye. He's got very constricted visual fields and very advanced glaucoma, disc damage in each eye. And he looks like this. And the question is, what do we do next? And when I'm asked this question, the pressure's in the 40s. They ask, what's the first thing you reach for? I mean, what medicine do you reach for first? My answer is, I reach for a gonio lens. Now, do I need to do gonioscopy on an 18 diopter myope? The answer is yes, because this is the person who actually had chronic angle closure. Now, what is the diagnosis here? Is it primary angle closure? Is it open angle? Is it phacomorphic glaucoma? Is it some weird syndrome I learned in school, but I can't remember right now, or I'm not sure? It's why I'm here. So 50-year-old male, minus 18 diopter myope. What's going on? Primary angle closure, open angle glaucoma, phacomorphic, some weird syndrome, but I can't remember what it is. Well, I'm not sure. That's why I'm here. Okay, this a little bit of a harder one. People are going through. We'll go a little bit more than a minute, then we will we'll share our results. So most people said open angle. Some people said primary angle closure. Some people said phacomorphic. Few people think it's a weird syndrome I learned in school. Can't remember right now. Not really sure. Actually, choices kind of 3 and 4 are sort of both right. Let's go back to our patient. Gonioscopy, chronic angle closure. But the key here is his optic nerves. They're advanced in glaucomas, but where's the staphyloma? For an 18 diopter myope, these do not look myopic. And that was the key to this for me. When I looked at the patient undilated and saw no staphyloma, no myopia back there, I knew what we were dealing with. And I can see that the lens maybe protruded a little bit into the anterior chamber. He actually had phacomorphic glaucoma from something called isolated microspherophakia. He had a small round lens. And that small round lens, one, led to pupil block and angle closure, and two, led to 18 diopters of myopia. Now, when I did an A scan, his actual length was about 24 millimeters, which is, well, pretty normal. So this is a person who underwent LPI successfully, followed by numerous glaucoma medicines, obviously. And then things did get complicated. This, one may say, well, very simple, just pop the lens out. I can tell you, a small, round, anomalous lens doesn't come out very easily without complications. Ultimately, he developed cataracts in each eye, and he underwent lens removal, cataract removal. And if I can remember what happened to him, he developed a MRSA infection. He developed cystoid macular edema. Of course, he had capsular pacification, and both IOLs dislocated and had to be repositioned. And as I mentioned, cystoid macular edema. So after all of that, multiple surgeries, and I've known this person for many years, I can say he's 20 happy. He's happy with his vision. So this is the shape of the lens. Phaco's lens morph is the shape. This is the most common of the lens-induced glaucoma. You have a unilateral or asymmetric cataract or some unusual type of lens development. And it can be difficult to differentiate from primary angle closure, but it's the lens that's inducing our phacomorph. Vision can be usually reduced from cataract, and this is increasing lens thickness and increasing iridolenticular apposition. And usually associated with a short axial length. But as I talked about, maybe it's not a mature cataract or significant cataract formation, but something like microspherophakia, which is associated with Weil-Marchesani syndrome. So this is a acute or chronic angle closure in patients with high myopia. So yes, high myopes can develop angle closure, but it isn't usual, and there's unusual reasons why. Greg, is that clear, or do I need to explain anything further?
No, that was very clear.
And again, how do we deal with phacomorphic glaucoma? Really, the aqueous suppressants are going to be fine. Interestingly, in chronic angle closure, prostaglandin analogs work well. They don't work well in acute angle closures, but they do work well, both before LPI and after LPI. Even when there's significant synechia, and we don't exactly know the mechanism there, but here's something to always remember. Chronic angle closure, prostaglandins work very well. Now we're going to start getting in toward the secondary angle closure without pupil block. Before I go on, Greg, are there any questions or comments that we need to address?
No, everything is good in the chat box.
All right. Well, let's look at secondary angle closure without pupil block. And there are really, again, numerous causes, but a few classic cases. Either the peripheral iris is pulled or pushed into the cornea. We have drug-induced choroidal expansion, neovascular glaucoma, neoplastic disease, inflammatory uveitic cases, and of course the ciliary block. Now I'm going to start talking about ciliary block glaucoma. This is kind of a hard one to explain and to grasp, but it is out there, and I'll give you a few clinical referrals. This is also known as malignant glaucoma, not in that it's fatal, but because it's a particularly nasty form of the disease. And it's also been known as aqueous misdirection syndrome. I don't think really any name is actually correct. But there's an anterior displacement of the iris and ciliary body. There's a swelling of the ciliary body. There's an attachment of the ciliary body, and the anterior vitreous displaces forward. Now, how can we tell? Well, there's a disparity in the chamber depth between the eyes. It is not pupil block, so iridotomy doesn't work. and miotics can actually worsen it. Now, this is often caused by what's quote unquote misdirection of aqueous into the vitreous and into the posterior chamber. And when we blow up that vitreal balloon, that vitreal water balloon, it takes up space, and what it does is it pushes the anterior segment forward. Now, this usually occurs after surgery, after ocular surgery, typically after glaucoma surgery, and more typically after glaucoma surgery for angle closure. Trabeculectomy, tube implant after angle closure can often end up with malignant glaucoma. And this is a particularly hard thing to deal with. It doesn't respond well to medical or surgical glaucoma therapies conventionally. And this is what it looks like on OCT. It's a flattened chamber. The chamber has flattened. So what happens is, as part of ocular surgery, aqueous has now been misdirected and is now going into the vitreous. The vitreous has a relatively impermeable face, so it starts to fill up, but it can't get back out. And when that happens, when you start to blow up this vitreal water balloon, it forces everything forward into a flat collapsed chamber. No iris bombay, flat. It flattens, and there's your diagnosis. Now, what's the best way to do it temporarily? We can do neosynephrine, atropine, acetazolamide. Probably the best thing is vitrectomy and lensectomy. It's taking the vitreous out, taking the lens out, or actually popping that vitreal balloon, vitreal water balloon, with a YAG laser, if possible. Now, what is the lifeline I can give you here that helps you to diagnose malignant glaucoma? I've seen malignant glaucoma, and here's how here's how it really looks. It's a person who's had surgery. Usually had trabeculectomy. Now, after trabeculectomy, one of the complications that can occur is hypotony, overfiltration, leakage, and the chamber shallows. Okay, after trabeculectomy, shallow chamber, low pressure, it's either a leak or it's overfiltration. Okay. Trabeculectomy, angle shallows, pressure goes up, malignant glaucoma. Great, is that clear? Did I do a good job with that?
Yeah, yeah. That's a tricky one. Yep. But
shallowing chamber, low pressure, leak. Shallowing chamber, high pressure, malignant glaucoma. It's tricky. It's that simple. Neovascular glaucoma probably is the number one cause, or the poster child of secondary angle closure without pupil block. You get neovascularization of the iris and angle. There are a number of causes: central retinal vein occlusion, diabetes, carotid artery disease. These are all the very common causes. So what happens here is the retina is hypoxic, is oxygen deprived, oxygen starved. So it's going to release these 6 polypeptide proteins called vegetative or vascular endothelial growth factor, VEGF. VEGF is looking for healthy endothelial cells and viable capillaries from which to bud new blood vessels and reperfuse the eye. Most of the time in the retina, there are no capillaries. So it diffuses forward, and the first place it encounters viable capillaries would be on the iris, mostly on the posterior iris. So neovascularization will develop. The neovascularization develops, it comes along with connective tissue. And it grows along the posterior iris, through the pupil, across the anterior iris, into the angle. And of course, that VEGF can actually develop neovascularization right in the angle proper to begin with. And when the blood vessels get in there with their fibrotic connective tissue scaffolding support, it'll actually grab the iris, grab the cornea, zipper it shut together in peripheral anterior synechium. So it'll zipper it shut. So it grabs the iris, grabs the cornea, pulls them together, and sticks them shut. And that is neovascular glaucoma. No pupil block, aqueous can get through the pupil, but it can't get out because it's a sinical angle closure. So the first thing we start doing is looking here. I can virtually guarantee if you see this, there will be vessels in the angle. There will be sinical angle closure. And you'll usually go endoscopically, you'll look and you'll probably see areas of microhyphema. You may see some active blood vessels, or you may actually, typically, you'll be seeing just no structures, synically closed. So this will lead to broad areas of angle closure. There's inflammation with usually a very high pressure. It's usually very painful. Ischemia, dural ischemia, ocular ischemia is going to cause some pain. Vision loss is usually going to be profound because of not only the glaucoma, but the precipitating condition to begin with. These are people that have a relatively poor prognosis. Your goal here, for the most part, is to prevent a blind, painful eye. They are poorly responsive to medical treatment. Now, there are things that can be done, and there are certain patterns to follow. Medical treatment is initially used to stem the pain and ameliorate the intraocular pressure. So first and foremost, number one, atropine. Atropine 1% twice a day. Don't ignore it. I know the angle's closed. It works. It's necessary. A steroid 4 times a day for the inflammatory component. These all work. Then you can use aqueous suppressants. Beta blockers, carbonic anhydrase inhibitors, alpha-2 adrenergic agonists. I don't think the rho kinase inhibitors are going to do very much for us. Miotics are not going to be not going to be indicated. Prostaglandins is not going to be indicated. But we don't generally medically treat this type of glaucoma for a long term. I've always said medically treating neovascular glaucoma is like arranging deck chairs on the Titanic. It makes it prettier, but it's still going to sink. Ultimately, what these patients will most likely undergo are anti-VEGF injections. And they're very good at causing regression of neovascularization. But once their effect wears off, it comes back. That's why pan-retinal photocoagulation is typically done. Barbecuing the fundus is going to destroy the ischemic retina, reduce oxygen demand, and reduce the vasoproliferative substances being released. Greg, I think that you have a comment about this or a story about how well the anti-VEGFs work.
Yeah, it's pretty amazing. You have these angles that come in. You have these patients come in, kind of like that eye that Joe showed. You do a gonioscopy, and you see 360 degrees of neovascularization. Joe mentioned you might see a hyphema. Anterior chamber might have a microhyphema. Just florid neo. And from a branch vein occlusion, these are the ones that I've seen. Patients come in, pressures are whatever, 45, 50 elevated. And, you send them over to the retinologist and they inject them. And I've had these patients come back 24, 36 hours later. It's all gone. Amazing. Like all that neovascularization, maybe not the florid blood vessels, but the kind of the wispy neovascularization. Would have never believed it if I wouldn't see it. I just said to the patient, look, when you get a chance, I teach a lot. Can you come over and get some photos before and after? Just amazing how quick that they can clear that up and then go in and do the PRP.
Yeah, but once that that anti-VEGF wears off in 6 weeks or 8 weeks, you still have a hypoxic retina. It's gonna come back. And of course, going back here, what you first need to look for in these patients who have the sudden vision loss and vascular occlusion, look for a red hue just around the edge. This is fluorescent. This is very advanced. Look for that very subtle red hue right here. That tells you you've got a lot of vessels on the back surface of the iris, and you probably have vessels in there in the angle. But anti-VEGF and PRP are not going to open up synechia. Sometimes these patients will need glaucoma surgery, trabeculectomy, if only to temporize the pressure. But don't get atropine, predforte, some aqueous suppressants. Get them out for anti-VEGF, and the ultimate treatment will be barbiturate fundus with pan-retinal photocoagulation.
Joe, we have one of our attendees just kind of sharing a story about a patient that was poorly controlled type 1 diabetic patient on metformin. Pressures were in the 40s, had a lot of proliferation, and a lot of it got into the angles. I'm guessing the neovascularization. The retina looked like a war zone, showed up at 4 o'clock on a Saturday, claiming no problems and just wanting contacts. So they're out there. It's still to this day, you'll get these neovascular patients.
Well, here's another nice case. What's wrong with your eye? A 24-year-old woman came to me, emergently following a co-worker's remark about a dismal ocular. He said, "What's wrong with the eye?" She says, "There's nothing wrong with my eye." She goes, "Go look at yourself." She looked at herself in the mirror and saw something was wrong. So she came in very urgently. She was 20/15 in each eye. Everything was normal. Pressures were okay. But she looked like this, and the pupil was obviously misshapen. And we had areas of dragging and areas of atrophy, and she had one of the ICE syndromes. And looking at that, we have a very large area of peripheral anterior synechia. We still have some open angle here, open angle here. Most of her angle was indeed open, which is why she did not have any elevated intraocular pressure. But ICE syndromes, which really is a corneal disease, can lead to a secondary glaucoma. So these are corneal diseases where the endothelial cells are over-secreting this abnormal Descemet's membrane that will extend over the trabecular meshwork. And as that happens, it will start to contract and pull the iris into the angle. So no pupil block, but it's actually zippering it shut with synechia. Now, these are typically unilateral, more commonly affecting women. I have seen it in men as well. And, they're all the same. We have the essential iris atrophy, which we have multiple areas of discontinuity in the iris. We can have Chandler syndrome, where the change in the iris are relatively mild, but they have corneal edema at normal pressure because obviously the sodium potassium pumps have been disrupted by this abnormal secretion. And the Cogan-Reese or iris-Lever syndrome, it's really the same thing, because there's an anterior iris nevus that will be present. So these are all corneal diseases that can lead to a secondary angle closure with a zippering shut. Very difficult, should it happen, it can be very difficult. It's usually surgical. Treating the corneal disease is going to help, but they're also usually going to be needing a tube put in there. Medical therapy can work for a short while, but long term is relatively ineffective. Frankly, they may never actually develop glaucoma. Now let's talk about the choroid and what happens there, because that's involved. Choroidal expansion can heavily contribute to angle closure, because if the choroid expands, it's going to take up space. If the choroid expands by 20%, it takes up about 90 microliters of volume. And the normal anterior chamber is only about 100 microliters, so that really will flatten things out. Now, if the choroid expands and flattens the chamber, you go from 20 to 60 almost instantaneously. Now, this will lead to a forward movement of the lens and iris and the chamber and flattening of the anterior chamber. Now, how do we know? Flat chamber, not iris bombay, flat chamber. Change in vessel permeability can do this. Fluids, proteins, blood will get into this extra vascular space in the choroid and takes up volume. Now, what are things that have been associated with the choroid? Choroidal detachment, cavernous sinus fistulas, suprachoroidal hemorrhage, scleritis is a big one. Uveitis will lead to a vascular permeability. It will affect the choroid and give you angle closure. Some tumors, PRP, but what's more common that we need to be aware are the drug-induced choroidal effusions, and these drugs are usually sulfate-based. So there are a number of drugs that can cause angle closure. Diamox, believe it or not, acetazolamide, which we use, to treat angle closure, can actually cause angle closure. There are a number of things in there, but really the number one is topiramate, also known as Topamax, which is an anti-seizure medicine that has so many off-label uses, such as headache, mood stabilization, weight control, reducing the dependency, psychological dependency of alcohol. There's so many off-label uses. I don't know if it's used, if it's hardly ever used for seizures anymore. It's got so many off-label uses. But this leads to an anterior rotation of the ciliary body. This leads to thickening of the, reduce the tension on the zonules. The lens thickens. They become more myopic. The lens iris will shift anteriorly, and it will lead to shallow in the chamber and a potential for closure. And I think this is a nice example here, although there's a little bit of, I have a little problem with it from some of the depiction. This is how things look normally, but if we have increased vascular permeability and congestion in the ciliary body, it will swell up. It takes up space. It will force the anterior chamber forward and will actually flatten the chamber. Now, this looks like Iris Bombay, but it will really flatten the chamber. And here's a nice example of a patient, very, very narrow chamber. And we look at this is not Iris Bombay. What we can see here is it's a very, very flat chamber. Everything has been rotated forward. So here's a case, a 39-year-old female who has recently started on Topamax for migraine headache. She suddenly noticed blurred vision and eye pain. She was an emetrope. Now she's a -6 diopter myope, and her pressure is 44. So I think that brings me to maybe what will be my last polling question. What is the best management for this patient? Cycloplegia and steroids, Diamox, Cosapt and Lumigan, LPI, or I'm not sure. That's why I'm here. So she started on Topamax. She has onset blurred vision and a pressure of 44 and a closed angle. What do you do for this patient? Cycloplegia and steroids, Diamox, Cosapt and Lumigan, LPI, or I'm not sure. That's why I'm here. Okay, we're getting through this nicely here, Greg. All right. So we have number one is Diamox, which can lower pressure, but remember Diamox, there's a certain sulfa moiety in there, which can actually, if this person is sulfa allergic, can worsen things. I'm not sure. That's why I'm here. Well, what do we do in a patient? What do we do in a patient like this? Simple. Stop the Topamax. That in itself would be enough to probably cause this to reverse. But help it along, steroid, cycloplegia, beta blocker, alpha-2 adrenergic agonist, CAI, all going to work. What are the clues here? Well, an at-risk medicine. That's number one, Topamax. 2, bilateral. Primary angle closure is almost never bilateral. It's unilateral. This is bilateral. Flat anterior chamber, not our spine Bombay, but flat anterior chamber. And myopic shift. And how much they shift? They shift a lot. Not a quarter, not a half, not 75. We're talking 4, 6, 8 diopters. And most of the time, they're not in discomfort physically, they're in visual discomfort. They've lost their vision. And this person is probably refracted down to decent vision. But those are your clues. What we don't do iridotomy. Why do we do iridotomy? This is not pupil block. Unfortunately, there are a lot of people walking around with holes in their irides before this mechanism was understood. And now we realize we don't do an iridotomy in patients. It doesn't work. It's not pupil block. Now, questions that have come up is, what is the risk? Okay. I remember being at the university and one of my colleagues had a patient who was on Topamax. And my colleague was telling me that they're going to watch the patient every 3 months with gonioscopy. And the second the angle starts to narrow, they're going to refer them for an LPI. Boom, those are the worst things to do. Because LPI doesn't work. It's not pupil block. And 2, it is not a progressive thing. It is an abrupt thing. The vast majority of patients who have this happen within the first month of therapy. Anything beyond that, it is very unlikely. The only late onset cases that I know about with Topamax are patients who got their dosages increased. Usually it will happen. In fact, most of the time it'll happen after 1 dose. So 1 use can cause this to happen. They're a month out, it's not going to happen. Don't worry about it. And this is probably a self-allergic response that causes the congestion of the ciliary body and the angle closure. And this is what the patient looks like in initial presentation. We institute cycloplegia, steroids, aqueous suppressants. Over a period of time, it relaxes back. This is curable. And the pressure will come down, the angles will start to open. The myopia may linger for a while. It may take several days, in some cases several weeks, but it will come back down. So maybe malignant glaucoma is aqueous misdirection, but a form of choroidal expansion. And atropine is going to work by moving the ciliary body, backwards and relaxing. In some cases, atropine is a better choice than pilocarpine, which doesn't work in this condition. Greg,
Joe, one way to think of this when this happens, because I lecture with a pharmacist, and you've been on those lectures many a times, is to kind of think this is almost like a localized iritis, or you shouldn't say iritis, I guess. Iritis, ciliary body. And it's just kind of that localized. Ciliary bodyitis. Yeah, ciliary bodyitis. It's an inflammation. And that's why if you know how to treat an iritis, you wouldn't use pilo, you use some type of cycloplegic, go with atropine, go something strong in this way. You got, it's almost like a pachychoroid just in that ciliary body. So it's a very localized swelling, inflammation of that. And that's why, some type of cycloplegic, atropine, and then a steroid would treat this.
Excellent, Greg. Excellent points and support there. And I love listening to Tracy Offerdal. We have her many times. She is one of the smartest people that I've ever heard lecture. Well, let's wrap it up with what I call a case of the fist in the eye. He's a 75-year-old Asian male who's unremarkable medical history. Pseudophakian's left eye had been examined at our facility, it was fine, and gets accidentally struck by his grandchild and presents promptly 2 weeks later with pain, photophobia, lacrimation, redness of the eye, and nausea and vomiting that morning. Now, his pressure is 35 in the left eye, fellow eye is 17, and he looks like this. When we take a look at it, there are a number of things, and the first thing that I noticed is what appeared to initially, quote unquote, be cells. Maybe this is a traumatic uveitis, but that's not really it. What we see right here is this area of what I would call almost like an egg snap of vitreous that has prolapsed forward. And the IOL seems in place, but it seems to have reached around the IOL. It's actually touching the endothelium. There is some iris Bombay, and he's got, when you put a gonio lens on, he has got angle closure. So he's nearly completely closed. We have what would consider to be an acute angle closure. So the question is, can we follow this under what we do, historically? Diamox, will that work? Sure, aqueous suppressants will work. What about meiosis? This is an acute angle closure. Do we meiose this patient? Well, the answer is no, because while this is an acute angle closure, this is acute secondary angle closure, not a primary angle closure. And that's why it's important to think about what our mechanism is and approach it properly. The problem here is this pupil block because the vitreous has plugged the pupil. If I use a miotic, it's going to increase the plugging. What's the best thing to do? Okay, open it up. If we dilate the patient, maybe they'll allow aqueous to flow in. And that's what we did. I just simply dilated with tropicamide and phenylephrine, that are standard agents. After about 30 minutes, the pupil dilated, the angle opened, the chamber deepened. That vitreous was no longer wicking onto the endothelium. It came backwards. Pressure dropped down to 22. Put him on homatropine, 5%, which was available at the time, a steroid, a beta blocker, and referred him for he got several laser iridotomies, and ultimately that kept his ankle open, and he was successful. But the key is looking at the mechanism. There's acute angle closure, but it's acute secondary angle closure. Why is it? Is it pupil block? Yes. What is causing it? Vitreous prolapse. Do we use a standard therapy? No. We have to tailor the therapy. And that's why we have to think about what is the mechanism for angle closure. Now, what about revisiting gonioscopy? There are changing angle configurations. I think gonioscopy on a 2 to 3 year basis on all open angle glaucoma patients to see if a phacomorphism is developing and they go from a closed to open to a closed angle. Yes, every year I'll see a handful of patients that have been open all their lives that are becoming dangerously narrow. Of course, we can do iridotomies for those patients. So again, narrow angle glaucoma is an antiquated term. It's best to speak in terms of angle closure and what is the true mechanism. So with that, Greg, I think it's time to land this plane. I think we have met our hour and 40 minutes. Are there any questions I should be aware of?
There is a question that says, what is the percentage of patients on Topromax that develop angle closure?
That's a great question. I can't tell you the exact percentage. It's a relatively low percentage, but it is actually well reported. It's not an unheard of thing. It is not an unheard of phenomenon. I'm not going to say that 1% or 5% or 7%. I don't know. But I do know it absolutely does happen. And the best explanation I had ever read about this was actually in People magazine. Because topiramate was a relatively new medicine. They had an advertisement for it in People magazine. Of course, when you turn the ad over, there's three pages of product insert. They actually went through it with a really elegant explanation as to how angle closure occurs. Now, the important thing to remember is if it's going to happen, it happens pretty darn quick.
So, Joe, as we're wrapping up here, I'm just kind of curious just to see, has anyone seen this phenomena with Topomax or any of these other medications out there? I have. I've probably seen 2 or 3 in 20 some years of practice. While I have the privilege, I was able to hop onto PubMed here, Joe, and find a citation from 2012, topiramate and the vision, a systematic review, clinical ophthalmology, where they referenced 3 in 100,000. So very low percentage, but did I report the 2 or 3 that I saw? So probably a little bit higher than that. that's out there, but that was the site that I found from 2012 in clinical ophthalmology. But I know I've seen, like I said, 2 or 3. Joe, I'm sure you've seen them
Mhm.
out there, and no one's really weighing in whether they saw them in their practice. So it'd be kind of neat to see if any of the audience has seen this in their practice.
And for a while, until we figured out this mechanism and put 2 and 2 together, unfortunately, patients got a lot of unnecessary iridotomies. So with that, Greg, I'm gonna turn it back over to you so we can taxi into the gate.
Okay. It's kind of like Delta. You're going to land on a little bit ahead of schedule, and hopefully they can get the plane that's there in front of us is already out of the gate so we can pull up. So thanks everyone for being here. Joe, you did a great job as always. I think everyone just kind of thinks, how can you do 2 hours on angle closure glaucoma, and what would be the current thoughts? But you took, a complex and multifaceted type of topic. It made it enjoyable, and thank you for a great, well-rounded presentation.
Thanks, Greg.